Greetings and welcome to the International Pediatric Simulation Society podcast. This show is for people passionate about pediatric simulation-based education, training, and research. Podcast hosts are members of IPSS, a global community of multidisciplinary healthcare professionals from over 30 countries, all dedicated to improving the care of infants and children worldwide. Each week, one of our sub-hosts, Christine Bailey, Elaine Ng, Aaron Karn-Bennett, and myself, Samreen Vora, will introduce you to a new guest and bring you into a conversation with simulationists and healthcare professionals from across the world. Come along.
Welcome to another episode of the IPSS Podcast. I'm Elaine Ng, one of the co-hosts on the podcast committee, and I'm delighted to have Dr. Lennox Huang joining us for a conversation. We get to hear about his experiences and views on simulation, and also from his lens as a healthcare administrator and critical care physician. Lennox is the Chief Medical Officer and Vice President for Medical and Academic Affairs at the Hospital for Sick Children. He is also a pediatric critical care physician at the hospital and holds the rank of professor in the Department of Pediatrics at University of Toronto and associate clinical professor of pediatrics at McMaster University. So he has a special interest in the application of healthcare simulation to the design and testing of new facilities and in the detection of latent safety threats. He sits on the board as the co-president on the Global Network for Simulation in Healthcare. So Lennox, we met years ago at IPSSW in Madrid. What year was that, you think?
Yeah, that was a long time ago. So that was probably my second IPSSW. My very first one, I do remember my first one was in Florence. That was 2009. So Madrid must have been 2010. So,
and Madrid was the third IPSSW.
Yeah.
That was my first conference. Back then, you were at McMaster Hospital, which is about an hour away from Toronto. And you were the founding medical director of the SIM program there. Tell us a little bit more about what it was like then and what you had to do.
Day.
Yeah, exactly.
Yeah, well, so, I've been really, really fortunate to have been in the right place at the right time. And that's what happened for my career in simulation. I started out on faculty at McMaster in 2004. And as a pediatric intensivist, it was a very early career at that time. But what I knew is I loved doing resuscitation training. I loved teaching. And I knew about these simulators, but I'd never really worked with one. And back in those days, hospitals actually ran surpluses at the end of the budget. I mean, this is such a foreign concept to us now.
Wow.
But it was not uncommon where at the end of the fiscal year, hospitals would have a little leftover and there was a scramble to spend the money. So in my first year there on faculty, there was a scramble to spend the money. And I was already involved in doing some teaching of PALS and resuscitation, things like that. I said, well, you know what? I can find a great use for that money. And we bought a couple of mannequins. They were Medi-mannequins at the time. I know it's not to sponsor them or anything, but they were Medi-mannequins. And we started the SIM program that way. So for a long time, the simulation program, which remained largely an in-situ simulation program, started roughly end of 2004, 2005, and it consisted of mannequins and task trainers that sat in my office because there was no place for it elsewhere. And it was a coalition of the willing. We brought people together. We trained up a bunch of folks. And these were early days especially for pediatric simulation. We were amongst the first places in Canada to have a pediatric simulation program.
Yeah, I think you were really an early adopter because the pediatric mannequins, high fidelity pediatric mannequins as we know it today, probably only came out early 2000.
Yeah, that's right. They were rudimentary. I even met, I think it was the 7-year-old boy who they modeled the pediatric mannequin after. It was one of my first sim conferences, and I met him, and he was far cuter than the mannequin. That's what I would say. But it was the early days of simulation, and in the early days of simulation, it was wide open. You could be trying all sorts of things. There were things there was a beginning of dogma around a lot of simulation practice, but really there was a lot of exploratory work being done. And a lot of articles were being written about how do you start a sim program? What do you do with that sim program? So that was my start early, about 2005 or so. I started going to conferences shortly after that, meeting people who were, I found there's all this excitement. These were great folks. They were eager to try new things. And at the same time, I met people who were super experienced. So the people were relatively senior, both in my field of critical care, but also in teaching, medical education, and otherwise. And you can meet them at places like IPSSW, which I thought was so fantastic. Meet them, have conversations, and then eventually do stuff. And what I found over time is that these people ended up being some of my best friends, colleagues. And if any of you are listening who happen to be amongst that group, and I think there are so many of you out there, you know who I'm talking about, some of my closest friends and colleagues around the world. And we've done really neat things over the years. So yeah, the early days were fantastic. And a lot of what I did at that time was teaching, which is a lot of what everybody did. But around close to 2008 to 2010, I started getting into administrative roles. And that's where I started shifting, because I found that I didn't have time to do all the teaching that I was doing before, and started to see where you could meld simulation with what I was doing in the other part of my career, which we started to learn about leadership and administration, quality and safety, and how you run a hospital.
Was that when you were starting to do things with the design and testing of new spaces and the lean projects that you did? I remember your presentation. I was so impressed. Seriously, so impressed. It's like, wow, this is amazing. I need to know this person.
Yeah, well, a lot of it, again, it's being in the right place at the right time and being fortunate to learn different things and then try and draw the connection between the dots. That's really what I would say it is. So we were starting, the patient safety movement across the world was really starting to blossom. And so I was learning about that. There was a lot of enthusiasm for things like Lean Six Sigma, and I've gone out and gotten my green belt in Lean Six Sigma. I thought, well, surely there's some overlap here with simulation. And at around that same time, we needed to renovate and rebuild some aging facilities at McMaster. So we had to rebuild our emergency department. And the hospital was undergoing a transition from being a mixed general hospital to being purely a pediatric hospital with really dedicated facilities. So we built a Pediatric Critical Care Unit, and the emergency department was overhauled top to bottom to accommodate pediatric patients and a much higher volume than what we'd seen before. So that opened up the opportunity to say, well, surely, again, there's more to simulation than teaching resuscitation algorithms. And perhaps we could do something really innovative. And, I was not the only person who had that idea. The really neat thing is around the same time in so many different cities across North America and the world, people who were in the sim space, there was a small group of us, were having similar ideas. They said, well, surely there's much more to simulation. And I think that question about surely there's much more to simulation is really what draws me back to the field over and over again, because I see that happening in system sim, I see it happening in education, I see it happening in a variety of different areas.
That's incredible. I mean, we're still doing these types of sims to test out new spaces, but can save money, avoid a lot more headaches later on down the street. But that must have been quite difficult to do because you guys were pioneers.
Well, it wasn't easy. I think part of it was the part that was easy was that I knew a bunch of people were just eager and willing to try new things. So finding the people who would be willing to participate in a simulation like that was not hard. And interestingly, finding help from outside wasn't hard in part because of IPSSW. So some great friends and colleagues who I connected with ended up coming to McMaster to help us out. Came to Hamilton, and there we were starting to hold workshops about how to do this and the things we had to consider, and we were getting practice and we were sharing ideas. So that part was the easy part. The part I would say was the hard part was, I was pretty junior in my administrative and leadership career, and I didn't fully understand, even back then, despite having a leadership role, how to insert simulation in a way that what you did really mattered and would influence or change what other leaders did and what the administration and the hospital did at the end. So, things that I'd learned pretty early on that, I'm not saying it's so much easier now, but they were great lessons at that time.
I think that make you a very unique position to provide some insight and advice to others, because right now you've gained way more experience as a healthcare administrator, being the CMO of the Hospital for Sick Children and VP of Medical and Academic Affairs. How does that marry with your role as a clinician? You still do your share in the critical care unit. What are the opportunities now that we can do simulation? It's so expensive. Yes, one can be creative and use other resources. But it's expensive in terms of being labor intensive as well. You can only get so many learners through. So what are the opportunities?
Well, maybe I'll start. I'll share just a quick anecdote. I've got a couple of kids, and one of my kids a number of years back was trying to come up with an idea for their science fair. Come with a project for the science fair, and they came to me and said, I don't know, I can't come up with anything because, Daddy, all the ideas, any good idea has already been done. And I can't tell you how many times I've heard that, not from other children, but like from people who are trying to start out. There's this feeling of like, and it's a bit of a defeatism that, so much great stuff has happened. All the good ideas are done and I think it's, if anything, that it's the opposite that's true right now. I think we're at a phase where there are so many neat things that are possible. And, whether you're talking about AI being integrated in things, or perhaps what we'll see soon is more robotics coming into play, a lot more integration with research in a way that's a lot more rigorous than what we did in the early days. I think all of these things actually uncover a treasure trove of opportunities that are out there. And so, I think the clinical part's really important, but not everybody's a clinician. And for those who are, just keeping your mind open and making observations about what you're doing, and just thinking, every time you see a patient or a family member, is there some connection that could be drawn into the sim world, whether it's an actual mannequin or it's a virtual mannequin or it's an augmented extended reality experience? I think there's an opportunity there for a question to be asked and innovation to be sought. And that constant thinking back and forth, how does simulation influence practice and how can practice influence simulation is one that if you keep that in the forefront of your mind, there's inevitably going to be something that comes out from there. I actually think there's a lot more opportunities for deeper integration into healthcare systems. It's easy to get pessimistic about this because a lot of healthcare systems around the world are facing deep challenges or have faced deep challenges. But I would say that if you look at the work that's being done in simulation, we're now seeing evidence of really significant impacts, either cost savings, and there's great examples of that. Our colleagues in Atlanta who have taken this idea of testing spaces and put it on steroids to the extreme and really done fantastic work to show the impact of simulation in pre-construction phases. Or to our colleagues who had tremendous success in Africa with a low-cost intervention that has saved just I think it's thousands and thousands and thousands of lives and continues to save thousands of lives. So, there's great evidence out there. And I think this is going to spur more innovation. People are going to start thinking even more about, so how do we take that, tweak it, apply to our local context, think about other opportunities to rise from that.
I would think is that probably we are now at an advantage because it's more accepted by our students and newer learners. Because sim is everywhere. Back then, many people did not know what we were up to. They see us rolling around the mannequin and they run the other direction.
I think you're right about that, Elaine. Like the simulation is an expectation of our learners. I think that's a given now. I can't think of any program, whether you're talking about an undergraduate program or a postgraduate program, where people would not assume that there's some degree of simulation involved in that. And there's varying degrees and there's varying levels of acceptance. And I think there's still work to be done to show that simulation can take the place or be additive to clinical exposure with real patients. But, it's an expectation. And I can't think of programs out there that wouldn't have some degree of simulation built in, which I think means that people will be primed for the future when they become practicing clinicians or researchers or whatnot to say, well, where's the simulation?
With that in mind, it also reminds us we don't always have to be that innovative person. We always have new learners. So to do the same old program is okay. I was reminded before that it may be same old for me, but it's brand new for the learners. So I just need to keep doing it well. So I don't need to be that innovative and find something new to do, because the great ideas from before are still great now. You still have to teach resuscitation and CPR and how to break bad news and all the other building blocks that makes a good clinician.
That's absolutely right. I think there's a lot we know. This speaks to healthcare more broadly, right? There's an implementation gap that's out there, and that you could take that and apply that framework to simulation. So it's great if you come up with a new program, a new offering, but if it only reaches 5 people, it doesn't have the same impact as something that's good and consistently delivered to hundreds or thousands of people over time. And that's actually a lesson that I learned from one of the professors at McMaster, not in simulation at all, but in medical education. It was Elaine Ng, who was program director for a residency program for a long time at McMaster. And when I was looking at her CV ages ago, she had shown how she could have impact in an educational way. And one of those ways is actually by noting how many individual students' lives you've touched in terms of what you've done in education. That's something that I don't think we always did with simulation. It's not always easy to capture. I think it's becoming easier to capture that kind of information. And, you can demonstrate impact in all sorts of ways.
Now, tell us a little bit about the Global Network for Simulation in Healthcare.
Yeah, I'm the co-president for GNSH. I've been involved in GNSH for a bit over 10 years now. And my entry point into that came from 2 pediatric colleagues, actually. It was Mary Patterson and Michael Soropian, who were past presidents of the Society for Simulation in Healthcare. And we knew each other, but not well. And they said, hey, Lex, you should get involved with this group because it's a bit of a different group. It's a small group, and it was made up at the time in 2015 really of leaders of societies, academic societies, and industry leaders. So almost equal representation. We had CEOs, vice presidents of some of the major players in healthcare simulation from an industry standpoint. And we had people who were leaders in education, leaders of sim societies, royal colleges, things like that, all coming together with the goal of trying to promote simulation. That was the initial goal. How can we figure out a way of getting simulation more integrated in healthcare? Because we all believe that simulation has the potential to solve some of the biggest challenges in healthcare. So that original goal hasn't shifted a lot. How we've applied it has changed over time. So we've covered things like health human resource crisis, COVID, of course, during the times of COVID, patient safety. We're starting to look at AI and planetary health as well. But we've never lost the global focus, and we've never lost that idea of trying to empower leaders, whether you've got an official title or not, leaders to spread the word of simulation and integrate it a bit more. So that's kind of the mission of GNSH. And we're continuing to do that. It tends to be a relatively smaller group of people, which there is a certain magic in that, because you get that collaboration. And what we hear back is from people who are our leaders. They say, this has really changed the way I've run my company. It's changed the way I've thought about focusing the society. A while back, Chad Epps was the president for GNSH, and then he had a term too as the president for SSH. And what he took it and continued along was this focus on patient safety. And that ended up being a theme that started to run more deeply in terms of the work of simulation. So that's our goal, and we're keeping at it. And what we're doing is forging as many relationships with groups around the world, trying to empower smaller societies and niche societies to do their work and help them along.
And also with industry as well, because we can only do so much. If they're not at the bedside, they don't know what we need. It's hard for them to build equipment for us.
One of the striking things, so a number of years back at a GNSH meeting, I brought a couple of colleagues, one of whom was a CEO of a larger community hospital. And I brought them to one of our summits, one of the GNSH summits, and we did a session. And in that session, the CEO was fairly blunt. They said, I'm not an expert at simulation, but I get that you've got this paradigm where you run a simulation and then the debriefing is going to be about 3 to 4 times the duration of that simulation. So tell me how that's ever going to work in the clinical setting. People are run off their feet taking care of patients. How do you carve out 45 minutes to an hour in a day to run a 10-minute, 10 to 15-minute simulation followed by 45 minutes of debriefing? And some of the people who had never heard this, they just didn't hear that reality before, including some of our industry partners. And they realized we're going to have to think about how we develop products, set them up in a way to be used, and alternate paradigms to encourage the uptake of simulation. So that was a really powerful moment. Last year, we brought Systems CEO, Dr. Kevin Smith, who's the head of UHM, the largest hospital system in Canada. And we did a fireside chat with him. And Kevin, a really bright guy, said, and he's a believer in simulation. Mm-hmm. They support it through the Wilson Center, which is a large education center here. And the Michener, they support a large simulation program. But he said, I wonder if there's a little bit of a branding issue and a nomenclature issue, and whether sometimes the terminology you use, including even the word simulation, is a barrier to connecting with people who are running healthcare organizations. It almost seems a little bit like a way of hiving off and a barrier to communicating what you're actually doing to those people who might be decision makers, the people who may have the resources to help you accomplish what you're looking to do.
So what did he suggest?
Well, like any great administrator, he doesn't give you a straight answer. Right?
I thought so.
He prompts you to reflect and says, well, why don't you go off and try and answer that question yourself? But he did say that, I think the lesson from that is that if we want simulation to be really successful and integrated widely, there's a couple of things. I think we need champions who are leaders or in leadership positions. I think we have to be really nimble and think about different ways of communicating what we do. And as much as, I'm an academic and I understand it's easier and comfortable at times to use academic terminology, that doesn't always fly with the people who are making decisions around resources. So I think we have to be nimble and think about different ways of communicating to all sorts of different audiences, the importance of what we do, and being able to capture their attention and to be drawn into it.
I saw that the registration is open. Who should attend?
It really is meant for people who are leaders. Now, that doesn't mean you have to be a CEO. It doesn't mean you have to be a vice president or a dean or the head of a society or the head of a program, because I think there are many people who are influential and leaders in their own right. But if you are in a position where you are either an existing leader of any sort, or you are an emerging leader, because we certainly have emerging leaders who come to attend this, or you're interested in these big global issues, then this may be a thing for you. It's a fantastic way to meet a really dynamic group of people from around the world. It's going to be in Copenhagen at the end of October. There's things on the GNSH website. There'll be things posted across social, including things like LinkedIn. So consider it and take a look at the offerings and see if that's the thing that you'd like to be involved with. We certainly look forward to having IPSS leadership there, and I think it'll be a great event in October.
Yeah, it sounds like it's a great event to hear from people who are at cutting edge of what they do. And also, as you said, the Dr. Smith, who kind of probably doesn't hang out in our circles in simulation, but then as an administrator, he kind of shakes us a little bit in our roots and just reconsider what we're doing.
That's always been a part of what GNSH does. We try to draw in people who might be simulation adjacent. I think that's probably the best way of putting it, so that there's relevance to our field, but perhaps not caught up in the bubble of our field.
You also partner with other organizations, because it's not about GNSH, IPSSW, not about SSIH. We need to work together. If somebody's got the secret sauce on how to do it, we should just advocate and distribute that information.
Yeah, it's that idea of all boats rise with the tide, right? And that's what we're looking to do. And I can tell you that just even over the past year, I've had amazing conversations with some of our colleagues from around the world, and clinicians, non-clinicians, pediatric, non-pediatric folks. We're all facing similar challenges, and we're all looking to try and solve it. So coming together, we're going to be stronger.
Yeah, because you're talking about AI, planetary health, workforce, resource issues. That's what all of us face.
That's right. The biggest challenge is in healthcare. And if we can solve it, then
that would be amazing.
We're going to all be better.
But we just need to keep working at it together.
That's right.
All right. Well, thank you so much for having this conversation with us. Very enlightened as to what's on our plates, what we need to work on in the future.
My pleasure. Look forward to seeing some of the folks who are listening at a future IPSSW.
Thank you for listening to this episode of the IPSS Podcast. A special thanks to our behind-the-scenes producer, the talented Danish Kumar, and to the Starship Foundation for providing the equipment that makes this podcast possible. Join us next time.